Section 3 is the current clinical examination. This is designed to be practical and something that can be performed in the clinic. It's not meant to replace the full neurological examination. This part of a scale is purely objective and based on the clinical findings in the examination. For question 1, visual acuity, it's important that the patient is assessed using their normal glasses or contact lenses, and if they haven't brought these, then the use of a pinhole. When we look at this, we use something called combined Snellen denominators to take into account disease of both eyes. So for example, if the visual acuities are 6/9 and 6/18, then the combined Snellen denominator is 9 plus 18, which equals 27. On the scale, this would score 2. Where acuities in any given eye are less than 6/60, then we still use 60 as the denominator for that eye. And what I'm going to do is hold up the Snellen chart and take that to the appropriate distance. It's very important to have the right size Snellen chart and to move it to the correct distance to achieve accurate scores. So this is one that's designed to be read at 2.4 metres. So Sylvia scored 6/12 in the right eye and 6/9 in the left eye. So combining the two Snellen denominators, 12 and 9 makes 21, and hence she scores 2. The next part of the examination involves assessing ptosis. It's very important for this section to ask the patient whether they have ever had previous surgery, because this affects the scoring. So Sylvia, have you ever had operations on your eyelids to lift them up at all?
No.
Okay. So knowing that there has never been any surgery, we can assess the degree of ptosis in its own right and apply that to the scale. Do you mind popping your glasses off for us? Okay. And if you just look straight across for us, if I could just ask you to sit slightly forward and just look straight over here for me at my finger. Now, looking at the eyelids, they do look slightly tosed, but it's very subtle. Both of the eyelids are not obscuring the pupillary apertures, so I would be scoring that as 1, mild ptosis, but not obscuring either pupil. As we discussed earlier, it's very important to note any previous surgery, because had Sylvia had previous surgery to lift both eyelids, then what she would have been scoring would have been number 4, bilateral ptosis obscuring more than 1/3 of the pupils, or prior bilateral surgery. Next, we're going to assess chronic progressive external ophthalmoplegia. So we're going to look at Sylvia's eye movements, and we're going to assess the range of movement in each direction. We tend to score this predominantly on the range of movement of abduction, simply because that's the least affected movement in patients with CPEO. So Sylvia, if you could just look at my finger for me, and if you just keep your head still, and just follow my finger wherever it goes. Look right at my finger, and then follow it back this way, and as far as you can. Back to my finger, and if you look up as far as you can, I think you can note there's some restriction of up gaze. And I'm just going to hold your eyelids slightly so we can see, and follow my finger down. And relax. Okay, so I think it was apparent there that there was some limitation of up gaze, but abduction, adduction and down gaze appeared preserved. So in Sylvia's case, we would be scoring that as number 1, some restriction of eye movement, but abduction complete. Next, we assess dysphonia or dysarthria, and that's simply by listening to the patient's speech. Sylvia, could you just count up to 10 for me?
Count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. Sylvia, would you mind just saying, the quick brown fox jumped over the lazy dog?
The quick brown fox jumped over the lazy dog.
Okay. So, just through normal conversation and also through using those phrases, there doesn't appear to be any dysarthria. So now we're going to assess myopathy. Sylvia, can you just pop your arms up like this for me and push up as hard as you can up to the ceiling? Don't let me push down. Really hard, really hard, really hard, really hard. Okay, well done. Okay, so I would be scoring that as an MRC grade 4/5. Can you pull up like that as strong as you can for me? Don't let me pull away. Okay, and this one really hard, don't let me get past you. Okay, so again, I'm overcoming that quite easily in biceps. Again, 4/5. Just take my hand like that, push out straight, hard as you can. So push me away, straighten your elbow, hard as you can. Okay, and again, this side, hard as you can, push out straight, straighten your elbow. Okay, so again, so I'm scoring 4/5 power in shoulder abduction, elbow flexion and elbow extension. Right, so we're just going to check the reflexes. That's probably not evident on camera, but the biceps jerks are present. Can I just take your arm there, Sylvia? Just let that relax. Triceps jerks, just relax there, are also present. If you just let your arm relax, and the same here. But the supinator jerks are absent bilaterally. Okay, so next we're just going to lie Sylvia down on the couch so that we can check the strength in her legs and also the lower limb reflexes. So just testing muscle strength in the legs. Sylvia, if you could lift this leg straight up and keep it up as hard as you can. Don't let me push down, don't let me push down. The same in this leg. If you lift that up as hard as you can, hard, 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 hard. Okay, so again, scoring 4/5 in terms of the MRC grade. If you could just bend that leg for me, bend that knee, and then just push out straight for me. Straighten your leg, hard as you can against me. Push, 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 really hard, really hard. Okay, and relax. And then this one, push out really hard, hard as you can. Okay, that's fine. So there is some muscle weakness in knee extension. Although it's quite strong, Sylvia does struggle to overcome me when I try and resist her. Okay, so we'll just check as well. If you just bend that knee again, keep it stiff. Don't let me pull out straight now. So pull your heel to your bottom, hard as you can. Don't let me pull out straight. And relax. And now this one. So just bend your leg for me, keep it stiff, and pull your heel to your bottom. And don't let me pull out straight. Well done. Okay, so that's super. Okay. So again, there's just a little bit of subtle weakness in knee flexion as well. Now, Sylvia, could you pop your arms across your chest like that for me? And I want you to just try standing straight up from where you are. I'll catch you if you wobble at all, but just so we can see how strong your legs are. Okay, and then back down again. So we're just going to check the lower limb reflexes. We just take your legs, just let those flop for me, Sylvia. Just relax.
Relax.
Yeah, just relax, that's fine. And let that relax. Okay, I'm just going to bend your leg out slightly like this for me. Just let this relax again. Just let that go floppy. And relax again. And the same with this one. Just keep that relaxed there. And relax. Okay, so the knee jerks, difficult to elicit, and the ankle jerks were absent. I'm not going to go through the in-depth sensory examination, but we also assessed that to see if there are any signs of neuropathy alongside the dropped reflexes that we've already demonstrated. So we're just going to assess for any signs of extrapyramidal disease. So if you just let your arm relax, the tone is absolutely normal, and the same. Tone absolutely normal. Just with this hand, can you just do that as quick as you can? And the same with this one. Okay, that's absolutely super, that's fine. And can you now just put that finger onto your nose and just gently touch the end of my finger as accurately as you can, and back to your nose, and then backwards and forwards quick as you can. And then the other hand. Thank you. There's just a very subtle intention tremor and dysmetria. Can you just on your leg, can you just tap like this as quick as you can? And then on this one for me. And relax, that's great. Sylvia, if you want to just take a few steps towards the wall and then turn around and come back, and I'll walk with you just to make sure that you're not wobbly, okay?
Right.
Okay, and turn around. Okay, that's fine. I'll just take you here if that's okay. Now, I know you're going to struggle with this, so I'll just hold on to your hand. But if you can just try and walk down this line as if you were putting a heel over toe like you're on a tightrope. Okay, that's fine. So in terms of assessing myopathy, as we could see from Sylvia's examination, she had a clear proximal weakness in shoulder abduction and in hip flexion. She also had clear weakness in elbow flexion and a more subtle weakness in knee extension. She also had difficulty rising from a 90-degree sitting position. So I would score Sylvia as 3 on the scale. It's important when using the rise from a seated position in the scale to make sure that the seat is approximately 90 degrees. If the seat is higher, it's much easier to rise from it. If it's lower, it's much more difficult. Whenever looking at sections 5, 6, 7, 8 and 9, it's very important when looking down towards the more severe end of a scale, and particularly number 5, to make sure that we appreciate what is the major pathology that may have led the patient to require a wheelchair. Clearly this isn't relevant in Sylvia's case, but in patients who may have severe myopathy, cerebellar ataxia, neuropathy or other features, it's important, for instance, when assessing myopathy, to assess whether the patient would be likely to be in a wheelchair purely because of their myopathy, irrespective of the other factors. This can be quite difficult to assess, but this is why we look at all of the different components. Moving on to cerebellar ataxia, Sylvia clearly had an ataxic gait. She was completely unable to walk heel to toe without being at risk of falling. The upper limb cerebellar signs were relatively subtle, but because of the other features in terms of gait and heel-toe walking, she would score 3. When assessing neuropathy, the patients do need a sensory examination as well. We haven't included that in the video because of time constraints, but it's particularly important to check whether there is any glove or stocking sensory loss. It's also very important to check proprioception to make sure that there is no joint position sense loss. Sylvia has none of those things but does have areflexia, and so she scores 1. In terms of pyramidal involvement, there are no signs in Sylvia, so she scores 0. In terms of extrapyramidal signs, Sylvia has none of these. There are no signs of Parkinsonism or dystonia. She doesn't score on the Hoehn-Yahr scale, so she scores 0. For question 10, cognition, the Wechsler test of adult reading needs to be performed only once as a test of pre-morbid intelligence. The speed of comprehension test and the symbol search will be performed and provide raw scores, and these can then be turned into centiles. Those 2 centiles are combined to give an average, which then feeds back to give us the score on the scale. Where poor vision prevents use of a symbol search, the speed of comprehension test can still be performed by reading out the questions to the patient and noting the responses. In some patients who have severe visual and hearing deficits, they may not be able to perform this part of the scale. Section 4, the final part of the scale, utilises the SF-12 to assess quality of life. This is a patient self-completion questionnaire. I hope you have found this video useful. If you need further details, please visit our website or contact us directly. Thank you for watching.